Well, good evening, everybody, to all our audience today who is here to hear us talk about diabetes and cardiovascular disease. Now, like we're aware, diabetes is associated with a number of vascular complications. Diabetes is, in fact, a vasculopathy associated with both micro and macroangiopathy. On the micro side, like we're all aware, the retinopathy, the nephropathy, all of that comes with the onset of diabetes. But in fact, the macrovascular complications of diabetes, in fact, predate the onset of diabetes, in fact, come with the time of starting of insulin resistance in itself. And as a result of which, diabetes has been called a cardiovascular equivalent. In the past, when we had to prevent, when we're talking about preventing macrovascular complications, the thought was control diabetes tight, and maybe we can prevent these complications, the cardiac complications, etc., of diabetes. But now in our hands, we have available excellent medications that can help us deal with the cardiac complications independent of managing diabetes also. Now, to talk to us a little further about this inextricable link between diabetes and cardiovascular disease, we have with us Dr. Sonali Agarwal. Privileged to be able to introduce her today. Dr. Sonali Agarwal is an MD medicine with a fellowship in National Board of Critical Care. She has basically trained in Mumbai. She has trained in Australia and also has a degree, a certificate course in diabetes management as well. In her clinical experience, she's currently a consultant intensivist in emergency medicine at the Amalta Medical College from April 22nd onwards. She has also been a consultant physician and ICU in charge at the Madhav Nagar Hospital in Ujjain. She has held a number of different posts through her illustrious career with a lot of publications, a lot of involvement in multiple societies, conferences, meetings, and workshops, and also been a part of multiple clinical trials for OHAs. Welcome to Dr. Sonali, a warm welcome to us and this session of IJCP today.
So, good evening, all. So, today our main concern is to discuss about diabetes and cardiovascular diseases. So, as we all know, we can say that like diabetes and cardiovascular complications are like partner in crime because they go together when you talk in terms of complications to arise. So, can you share slides, please? So, to our today's topic is diabetes and cardiovascular diseases. They are partner in crime. So, how we will say this type of lines? Just will elaborate this. Next slide, please. So, as we all know, diabetes in India is a major complication. It will be there. Its prevalence is almost 9.6% among adults aged more than 20 years of the and above. And the number of people with diabetes in India is the second highest in the world. Previously, it was very less, but nowadays it's second highest in the world. In India, 1 in 11 adults are living with diabetes, and over 53.1% of the adults living with diabetes are not diagnosed at the time of presentation. 90 million adults living with diabetes in India nowadays. 1 in 2 adults with diabetes are undiagnosed. 747,000 deaths occurred in 2021 just because of diabetes and its complication. It's a huge number, so we should go further. Next slide. So now we'll talk about the cardiovascular diseases. According to the International Diabetes Federation, the prevalence of coronary artery disease among diabetic population is almost 2.5%. The studies have shown that more than 65% of the patients with diabetes die of the cardiovascular diseases, of which nearly 80% are attributable to coronary artery disease. So it's a huge number. Mortality after an acute coronary event is also 40% higher in Asian Indian population as compared to other races. So it's a very large number which is contributed to diabetes and its complication leading to death. Next. So this is a diagrammatic representation of diabetes and CVD in Pregram heart study, which is showing that female population, if it's associated with diabetes, they are having the higher mortality as compared to the male, and multiple risk factors. If patient is having multiple risk factor of CVD associated with diabetes, then chances of having complications and mortality is much more higher as compared to other risk factors. Next, this figure is showing the risk factors associated with cardiovascular diseases in diabetic patients. So, as we all know, diabetes is affecting at the multiple sites in patients. So, how it's affecting or it's causing the more chances of cardiovascular complications. So, when patient is diabetic, their skeletal muscles are having insulin resistance, high free fatty acid levels, and hyperglycemia. There is a hyperinsulinemia from the pancreas, which is attributing to insulin resistance, hypertension because of high LDL levels. Genetic predisposition is always there, and hyperglycation leads to advanced glycation end products and atherosclerotic predisposition. Associated with diabetes, there is again a lipemia, which is because of adipocytes releasing the insulin, INF factor alpha, CRP, and other inflammatory markers leading to dyslipidemia. And these all complications attribute to more chances of atherogenesis and attacks. So this multiple association leads to cardiovascular complications in diabetes. So this is a diagrammatic representation of pathogenesis of cardiovascular complications in diabetes. The mechanism involved in the pathogenesis of cardiovascular disease in diabetes comprehend epigenetic changes and intracellular metabolic changes that result in oxidative stress, low-grade inflammation, and endothelial dysfunction. So, what we all need to do for prevention of cardiovascular diseases in patients of diabetes? CVD can be prevented or delayed by controlling blood glucose, blood pressure, and cholesterol, and with lifestyle changes such as stopping smoking, eating healthy, and increasing physical activities. Primary prevention involves preventing or delaying new onset CVD in patients with type 2 diabetes, and secondary prevention involves treatment of risk factors in diabetic patients with established cardiovascular disorder. So, what therapeutic strategies are needed for this? Early initiation of combination therapy is an approach to achieve glycemic goals earlier and delay the deterioration of glycemic control with possible better preservation of the beta cell function. Novel medication therapies. These are used with diet and exercise to control high blood sugar in adults with type 2 diabetes. They are DPP-4 inhibitors, that is sitagliptin, sexagliptin, linagliptin, and alogliptin, SGLT2 inhibitors, canagliflozin, dapagliflozin, and empagliflozin, GLP-1 RA, that is glucagon-like peptide 1 receptor agonist, regulate and restores of incretin function. SGLT2 inhibitor and DPP-4 inhibitor combination is very helpful in preventing the complications of diabetes because they are targeting at three sites. SGLT2 inhibitors act at kidney as well as pancreas, and DPP-4 inhibitors act on pancreas as well as intestine. So they are having multiple benefits other than controlling the sugar levels. So SGLT2 inhibitors, including glucosuria, decrease glucose toxicity on pancreas. They have indirect pancreatic effect by increasing beta cell sensitivity and increase glucagon. DPP-4 inhibitors have dual pancreatic effects by increasing insulin secretions and decreasing glucagon. In intestine, they have incretin effect, so increases the GLP-1 levels and increase GIP. So they are helpful in decreasing weight also and decreasing uh, systolic blood pressure as well. Hyperglycemia is controlled simultaneously. The DPP-4 inhibitor is a weight neutral. So SGLT2 inhibitor and DPP-4 inhibitor FDC is a suitable option for Indian type 2 diabetic patients for the following reasons. They are safer, rapid, and sustained glycemic control. They improves the both insulin resistance and beta cell functions, helps in reducing body weight and blood pressure, extra glycemic benefit, reduces all burden, adherence, and comprehensive improvement, and overall cost effective. These are the major benefits of SGLT2 inhibitor with DPP-4 inhibitor. So, what are the cardiovascular benefits of SGLT2 inhibitors? It's a declaration that TIMI 58 trial showed that dapagliflozin was non-inferior to placebo with respect to the primary safety outcome of MSE and significantly lower rate of cardiovascular death or hospitalization for heart failure. So now, if you have any questions, so you can ask that.
Sure. So, Dr. Sonali, thank you for your presentation. Dr. Sonali, when patients come to you in your OPD, let's say, whichever patients are diabetic, do you believe that every single patient who enters the OPD who is diabetic, may be older, deserves some form of cardiovascular evaluation in terms of biomarkers, in terms of routine stress tests, or anything of that sort? Now that we know that the association between diabetes and cardiovascular disease is so high, do you believe that every diabetic patient with diabetes deserves cardiovascular risk assessment?
Definitely, because see, from day one, if patient is having diabetes, so it's having an additional risk factor for cardiovascular outcome. So definitely, any patient who is diabetic, he's having other risk factor associated also in terms of male gender or genicity or obesity or any other complication like dyslipidemia, hypertension. So it's a multiple risk factor which are associated for cardiovascular outcome. Definitely, any patient who came to our clinic and who were diagnosed to have diabetes, we are going for a general cardiovascular outcome risk assessment, and accordingly we'll treat the patient. So any patient who is having the high risk of having the other complications, so he has to control in that manner. And if it's like having less risk factor, accordingly we can manage.
So, do you believe that any cardiac biomarkers or imaging needs to be done? Let's say you have a patient 50 years old with diabetes, with hypertension, with dyslipidemia, smoking maybe, obese maybe. What kind of OPD based cardiac biomarkers or imaging do you put your patients through? Or unless they're symptomatic, you feel they don't need any ECG, stress tests, etc.
Mhm. When patient of this type of like a 50-year-old male patient who came with diabetes, the first thing to be done is the ECG. Once you are doing ECG and patient is not having any cardiac chest symptoms like chest pain or breathlessness, then we'll go for the echo. Today echo is a very basic OPD based marker for cardiovascular complications, and accordingly we'll go for further. If like patient is not having any signs of dilated cardiomyopathy or low ejection fraction or any other type of cardiac symptoms, then patient can assign for the TMT, that is a stress test. And if it's negative, then there is no need for angiography. But any patient who is having any changes in the 2D echo, ECG, and having positive TMT, then he will straight away go for the coronary angiography.
So
And
every
accordingly,
patient with multiple risk factors, you do believe that you would have an ECG and 2D echo done routinely for every patient also as
yeah,
well.
sure. Yeah.
All right. What kind of, lifestyle interventions do you advise your patients for diet and exercise in order to mitigate the cardiovascular risk for patients with diabetes?
See, all patients who are coming with diabetes and other multiple risk factors, so we are advising the low calorie, low fat, small meals, frequent small meals. Instead of having heavy one meal in the morning, like many of the patients say कि morning में बहुत सारा अच्छे से खाना खा के निकल जाते हैं, फिर आके सीधे रात में खाते हैं. So these glycemic variations, these are very hazardous for a diabetic patient, especially in terms of the cardiovascular complications. So we always advise low calorie, low fat, small meals, frequent meals with tight control of diabetes, especially high fiber diet and basically no low calorie diet.
And low carb also, I'm guessing, low
Low
carb
carb
diet
diet, yeah.
also as well. What about exercise? What do you advise your patients?
We are mandating every patient routine exercises at least for 5 days in a week and minimum 20 to 25 minutes per day. That's a minimum recommendation. But anybody who is like willing or who can adopt for, they can go for the significantly increasing the day by day incremental way of exercises in their routine.
And what do you advise your patients regarding alcohol if they ask you?
Alcohol, we usually say they should avoid beer or any type of alcohol which is in high calorie content or high carb content, but they can take once a week 50 to 60 to 120 ml once a week.
Right. I think the ADA recommends that they're allowed 2 pegs a day for men and 1 peg per day for females. But I guess in India
Not
that might be
daily, but
considered
it's once a week is okay.
right. How about
Yeah.
in terms of the strategies to employ to optimize the glycemic control while simultaneously reducing the risk of hypoglycemia for your diabetes patients with established cardiovascular disease? So what medications do you advise them with low hypo risk?
See, nowadays, previously there were only options of sulfonylureas and metformin, but now multiple drug categories are available, especially SGLT2 inhibitors and DPP4 inhibitors. They are having very low risk of hypoglycemia, and they are managing their effect by as per the diet intake of the patient. These are very safer available combination options and very easy. Like you can take once a day morning dose, and it will work for the 24 hours. So these are very good alternative options for patient, by which they can reduce the chances of hypoglycemia and simultaneously can manage the hyperglycemic index also.
Right. So I think as per the current guidelines for our audience right now, when a patient comes into our clinics with high risk of cardiovascular disease, multiple risk factors, the basic, the state of our practice basically dictates that every patient who walks into our clinics, if they are high risk, they need to be given one of two classes, which is an SGLT2 inhibitor or a GLP-1 RA that reduces cardiovascular risk. So this is for patients with CKD or cardiovascular disease or multiple risk factors. So as a result of
Sure.
which, this is irrespective of whether they are on metformin, irrespective of whether their A1C is even normal for that matter, every patient does deserve to have this as well. Dr. Sonali, what is the use of GLP-1 RAs in your clinical practice?
See, there is quite a hindrance for using the GLP-1 analogs in terms of the cost, because availability and cost is again a big issue. So I always prefer, like in our Indian setup, if a patient is obese, is having metabolic complications, and he came with metabolic syndrome, and he is the ideal candidate for like GLP-1 analog. But problem is the availability and cost. It's a big issue. So
Right.
right now it's not very prompt, like we can start in many patients, but
Yes.
definitely it's an option which we provide to every patient if like they can use.
Right. Do you feel so? Is availability a problem in a town like yours, or so in Bombay for that matter? Availability is not that problematic, but where you
Yeah,
are,
but
is that a
availability with
regular
cost
problem?
is a big issue.
The cost is a big issue. Correct. No, that I totally agree about. That lots of people will have a problem with regards to this. What
Because most of
strategies
the
do you?
public ones, like 500 or 1000 should be the cost of like their therapy for a month or so. That's their concern.
How often are you using the SGLT2 inhibitors and the DPP4 inhibitors in combination? Do you generally, let's say for a patient who comes with an A1C of anywhere between, let's say, 7.5 to 8%, diabetes, generally, what would be your start out strategy? Let's say if the patient also had hypertension, dyslipidemia, had multiple risk factors, what would be your starting strategy for medications for this kind of patient?
In these patients, definitely my first priority is SGLT2 inhibitor with DPP4 inhibitor associated with metformin also, because this triple drug combination is available very well. So if patient is having hypertension, dyslipidemia associated with diabetes also, then it's a benefit of this. And nowadays, cost of this combination is also very less. So it's a very good and preferred option to be used.
How often are you finding complications of like UTIs, GTIs for patients on your SGLT2 inhibitor drugs?
UTI, as we thought, like it was we were thinking that it may be a major risk factor to avoid, to withdraw this drug. But only you can say, as per now, I have seen only 5 to 10% of patient in which we actually need to withdraw this combination. Then we have to switch over to DPP4 inhibitor plus metformin, or sometimes to sulfonylurea also.
Right. Now, what do you think we can do as physicians to enhance patient education, the awareness about the strong link between diabetes and cardiovascular diseases, Dr. Sonali?
This is from the day one, we have to explain this. The day you are diagnosed to have diabetes, your atherosclerosis process, that is reduction of the blood flow to the organs, is started. So any day you can develop these complications. The only thing is like you can delay this complication by your vigorous exercise schedule, your tight glycemic control and control. All my diabetic patients, I am taking them as a primary candidate of CAD, and I am always giving them the secondary prevention. So antiplatelets, statins, and this combination, the I am starting off from day one, because I am taking all those patients as a primary cardiac patients when they are 40 plus and diagnosed to have diabetes.
Right. Okay, that's interesting. How do you feel diabetic nephropathy contributes to cardiovascular morbidity and mortality?
Diabetics are definitely having very high chances of having mortality and morbidity from cardiovascular complications. So it almost raising our this CAD effects in India at least by 20 to 30%.
And how does diabetic nephropathy play a role in this whole story?
Diabetic nephropathy is finally leading to very cumbersome complication of CKD and finally pertaining to dialysis and death. So it's a very deadly complication which is expected from the diabetic if diabetes is uncontrolled. So when you are taking care of diabetes, blood pressure and dyslipidemia, all three together as a whole, then chances of getting CKD is very less. And it is increasing with this, decreasing with this combination to a very great extent.
So, any last messages? This is International Women's Day is coming up, Dr. Sonali. Any messages for our women patients also from the point of view of diabetes, cardiovascular disease, etc.?
See, for all women, my message is because, especially in Indian setup, all women are very careless for their health and regular checkups. Males are usually getting their regular health checkups from their offices also, from their workplace, messenger, from their workplace also. But women are not taking care of their health. But women's health is also equally important as male. So they should go for regular checkups, and once they are diagnosed to have any problem, so they should not like reluctant for getting proper treatment care, and they should visit their physicians regularly.
All right. Thank you so much. And I agree so much to this. The theme behind this year's 2024 International Women's Day is improving inclusion. And I think that is so important for women, like you said, Dr. Sonali, to basically consider themselves worthy of getting themselves checked. Women tend to take advice not from doctors, but from their other women friends. They know the importance of getting checkups done, but they don't do that. They know the importance of exercise and diet, but 60% of women tend to miss a lot of meals and don't, exercise. Women are looked at as the stay-at-home people, where the men go out as the breadwinners. So as a result of which, women are putting themselves on the back burner at all times. So I think this message for all women on this International Women's Day that is coming up is take better care of yourself. Stay aware about the strong link between diabetes and cardiovascular disease. Manage the diabetes well. Help yourself also so that you can help the whole family, because you are the primary caregiver of the entire family as well. So thank you very much. Thank you to IJCP for having us. Thank you to Dr. Sonali for a wonderful presentation and discussion. And if there are any closing words, Dr. Sonali, please go ahead.
From my side, my closing words are always like that you have to take care of yourself, especially for women, because you are the mainstream of your whole family.